make sure this session is recorded. Before we get started, I just wanted to take a moment to introduce our presenters, Dr. Yankus and Mr. Nash. Dr. Yankus is a New Jersey native and a community-based pediatrician who did his pediatric training at New York University Hospital Bellevue Medical Center and internship at the University of Medicine and Dentistry of New Jersey. He graduated from medical school after teaching at the Taft School in Watertown, Connecticut. He is past president of the New Jersey chapter, who had been recipient of the 2007 Chapter Recognition Award and 2011 Pediatrician of the Year Award. He was chair of the chapter's Critical Issues in School Health Conference, and he also won the National AAP's Milton J. Sen Award for contributions to the nation's school health, and was the chair of school health for the National AAP. He practiced pediatrics in Midland Park, New Jersey, and is the medical liaison to Ridgewood Board of Education and Leonia Schools. Dr. Yankus is married, father of 3 young men, and grandfather of 2. Mr. Nash currently serves as director of Legal One at the Foundation for Educational Administration. Legal One is an innovative program that provides school law professional development for school leaders and other educators. From 2003 to 2011, Mr. Nash served as legal counsel for the New Jersey Principals and Supervisors Association. In that role, Mr. Nash provided legal assistance to NJPSA members for legal issues arising out of the performance of their duties. He currently teaches graduate level school law courses at Ramapo College and has previously taught at Rutgers University and New Jersey City University. Mr. Nash received his BA from Rutgers and graduated with high honors from Rutgers Law School in 2003. And at this time, I'll turn it over to Dr. Yankus and David for the presentation.
Good afternoon and welcome. David, I'll let you start.
Thank you. Thank you so much, Wayne. It's wonderful, as always, to be presenting with you. And thank you, everybody, for being part of this presentation. We know that you are participating at an incredibly challenging time, a time that none of us had planned for, but one that we are all working through together. So it's great to be with you and have a chance to talk about some important, evolving legal issues that we should all be aware of. As we walk through our presentation today, of course, we are going to touch on a number of evolving legal issues. As we do that, keep in mind we're not giving legal advice. We are trying to give you the latest available information. With that said, I do encourage you as we go, please type in questions to the chat feature, and we will do our best to work through as many of those questions as we can throughout our program. Just to give you a quick overview of what we're going to talk about in our time today, we're going to touch on the most recent relevant executive order, Executive Order 175, signed by our governor. We're going to talk about recent guidance from the New Jersey Department of Health that impacts on school districts and on all of you in your role. Of course, the New Jersey Department of Education and CDC guidance as well that impacts on your role. As we do that, we're also going to try to help you think through some issues of student confidentiality, trying to balance confidentiality and our obligations under FERPA and HIPAA is incredibly important. There are times where there is going to be some level of information sharing that we have to do. And there are some unique challenges, as we know, with the pandemic in trying to balance all those different interests. So we'll talk through that. As we go through the full presentation, we'll keep revisiting your role for many of you as school nurse and understanding those things that you shouldn't take completely on as your responsibility, that there are others who need to be a major part of this process as well. We'll touch on some recent legislation that you should be aware of, both COVID related and other recent legislation that still has to be implemented. And again, as we go, please jump in and type in questions that you might have, and we'll do our best to address all of those as we go along. I thought it'd be good just to kind of acknowledge where we are today as we're starting this presentation. As of yesterday, our numbers in New Jersey were over 214,000 confirmed cases of COVID-19, more than 16,000 deaths. For a large portion of the spring, we were second in the nation when it comes to confirmed cases. We still are second in the nation when it comes to deaths linked to COVID-19. So we do have incredible challenges that we have had to work through. At this point in time, we are frankly doing far better than much of the country. If you look at the transmission rates, hospitalization rates, our death rates. So we should feel very good about that. All the work that we have done collectively as a society here in New Jersey has made a difference. At the same time, there are some alarming trends that we're seeing recently over the last month or so. So some of our numbers are trending upward yet again, and we have to keep an eye on that issue. As of yesterday, the New Jersey Department of Health had confirmed 16 outbreaks in New Jersey schools with 58 linked cases. So Dr. Yankus, those are the confirmed outbreaks, but we would suspect that the actual number of individuals that we just don't know about is probably much higher.
Right. Since children are largely asymptomatic, we know that schools invariably have cases. These are simply the cases that have been confirmed. As we've learned from colleges and universities, when they were testing wastewater in dormitories, they came up with far more people than they had expected. So again, it is important to distinguish between the asymptomatic student who is attending school, either virtually or hybrid or present, from the confirmed who we have already isolated.
Absolutely. So as we get ourselves started, we do want to kind of ground ourselves in some recent requirements that have been put into place. Our governor did sign Executive Order 175, one of many executive orders that were specifically linked to this pandemic. This particular executive order required school districts in New Jersey to reopen in some form, but to reopen to at least some degree, allowing in-person instruction unless the school district was unable to meet health and safety standards. So we do have a number of school districts that did indicate to the state of New Jersey that they were not yet ready to meet those health and safety standards. Many of those school districts are planning to reopen to some in-person instruction this week, or have opened this week to some in-person instruction. Others are planning to do so later in the fall or perhaps in January. Many other districts have reopened and are providing a hybrid instruction. And a small number of districts actually are providing full-time instruction with all of their students in. We know that this executive order required development of local plans between the school district and the local Department of Health. So that is an incredibly important relationship. It always has been. I guess now more than ever, working closely together to address so many issues, including contact tracing, dealing with potential outbreaks, just general information sharing and laying out of responsibilities between the school district and the local Department of Health. Dr. Yankus, I know that when we talk about local departments of health, the amount of staffing and the local capacity just varies tremendously from one community to another.
It does, and the level of expertise in deference to the work they do does vary. There are plenty that have had training over the years and some that are quite new, and it really does make a huge difference in terms of New Jersey as to what town you're actually in.
Yeah, but regardless of where you are, I think we all recognize the importance of having a very strong relationship with your local Department of Health. Communication is key. It always has been. It obviously is very much so right now. So we want to build and maintain those relationships. The executive order also laid out the requirement for face coverings to be worn by all students and staff with limited exceptions. So we do want to understand that. The basic rule is that we are expecting everyone involved coming into our schools or onto our school grounds to be wearing a face covering. But there are exceptions if doing so, for example, would inhibit the individual's health. There has been widespread misunderstanding of this particular exception. So again, Dr. Yankus, it is an exceedingly small number of individuals who truly cannot wear a face mask for health reasons.
Infinitesimally small, and this is where the confusion last spring came between the CDC, the DOH, the DOE, et cetera. But essentially, inhibiting your health means you've had altered facial characteristics through surgery or accident, or you have difficulty breathing through your mouth because of some sort of tracheal alteration. Theoretically, there is almost nothing that prevents you from wearing a mask except age under 2.
That's right. So sometimes we're going to want to, in the school community, follow up when you're getting notes that say somebody is unable to wear a mask for health reasons. This is one of those areas where having the school nurse and potentially having the school physician follow up and clarify that note with the doctor could make a huge difference, don't you think?
Therapeutically, it would be very important because school notes started to come in last spring regarding masks from all kinds of doctors. The important thing is your school doctor's job, along with the nurse, is to confirm, and you can do that legally, confirm with the letter writer as to explore the reasons for the inhibition to wear the mask and how that works within the school system and the current executive order. Many physicians' offices were unaware in the springtime of the mandatory face covering order, and many didn't really consider the fact that the student about which they were writing the letter probably could, over time, learn to wear a mask.
Yeah, and that's an important point too. These things are not permanent. There are instances where perhaps today, tomorrow, this week, a student for other reasons linked to their disability may not be able to successfully be expected to wear a mask all day long. But for the vast majority of students, that skill can be developed over time. So even if it's not possible today, it may be possible in 2 weeks or a month if we continue to work with that student. There are other exceptions to keep in mind. So if someone is exposed to extreme heat outdoors, that would be an exception to wearing a mask. If there is an emergent issue coming up, somebody is having a medical problem, is having trouble breathing, is unconscious, incapacitated, or otherwise unable to remove a face covering without assistance. You could have some emergent situations where you wouldn't have a mask at that moment. But again, these are temporary isolated issues. As we just mentioned, you could have a student who has a documented issue in their IEP or 504 plan that precludes the use of a face covering. But with that issue, you really want to have ongoing communication with the IEP team or the 504 team. You want to press to make sure that is necessary, the idea that the student is unable to wear the face covering. And again, work to address it over time so that isn't a permanent condition. We may be dealing with face coverings for the foreseeable future.
I would recommend this because it is usually the special needs student or the family of the special needs student who is requesting no mask. If you establish in your school system a protocol, who gets the letter first, to whom does it go? In many schools, the nurse may receive the note for no mask, who usually passes it on to the director of special services who handles the IEP or the 504 plan, and then up to the principal. The school doctor should be the last person to get that note because essentially it is an administrative issue. But if you have an established protocol as to how to handle the mask refusal, you are less likely to have a lot of mask refusals.
Hank has mentioned children under 2 years of age. We cannot require a mask for those very young children. I think it's obvious you don't require a mask when a student is eating or drinking, and we do have to provide access to meals for all students, even though we are in many districts finishing our school day much earlier. You could provide that meal for students as they are leaving, but we have to make sure we at least are providing those meal opportunities for students. Breakfast and lunch where required. If someone's engaged in high intensity aerobic or anaerobic activity, for students who are involved in athletics or in phys ed class, if there is some high intensity activity going on, at that moment, they don't have to be wearing a mask. But at many other moments during that practice or during that class, they would be required to wear a mask. So this requires a tremendous amount of diligence. Our coaches need to understand that when students are on the sidelines, not actively participating in drills, they should be wearing that mask. And for portions of a physical education class where students are not actively engaged in high intensity activity, they should be wearing that mask. So these are, again, supposed to be narrow exceptions. When a student is part of a music instruction is playing an instrument that would be obstructed by the face cover, we know you can't wear the mask at that moment. If it creates an unsafe condition and the student is operating equipment or executing a task, but again, that's incredibly rare that we would actually have to make that exception to wearing a mask. When it comes to mask wearing, trying to figure out, how many masks should we be providing in school? What should our planning process be? For some of you who have started allowing students in school, at least partially for hybrid approaches, you're figuring this out because you're looking at the demand. You're seeing how many kids are forgetting to wear a mask. Occasionally an adult might as well, and you have to provide a mask in those situations. So you want to make sure you're planning to have extra disposable face coverings for students. The Massachusetts Department of Education did put out a memo. New Jersey hasn't endorsed it, but they did cite it as an example that we can look at that was very specific in providing guidance on the amount of supplies that we should be purchasing, depending on student population, age, grade levels, particular circumstances. So it's a very useful document that I would encourage you to take a look at. There is a link to it built in this PowerPoint, but you certainly don't want to run into a situation where you are lacking either masks or enhanced PPE that we need to have in certain situations. So Dr. Yankus, do you want to talk a little bit about perhaps the enhanced PPE that a school nurse should be provided?
Right. I think we learned again at the beginning what was important was hand washing, social distancing, and masks. But when it came to taking care of sick children in school, the nurse has an additional risk factor because she or he has to be close to the student. So we talked last spring about masks, face shields, gloves, and disposable gowns. If you have those, use them. Do not be afraid to protect yourself. Many nurses simply went with scrubs, which they could throw in the wash when they got home, as opposed to wearing their regular clothes. I think it depends on your office, the amount of space. It depends certainly on the amount of airflow where you are, but you'll be going in and out of an isolation room. So my recommendation is use what you have and use it carefully and use it well.
And do not be reticent to let others know if you need additional supplies. Document that. So we know that the New Jersey Department of Health has put out guidance that we mentioned. It was first released on August 13th. It was updated on September 8th as schools were starting in many places or had just started. So we do give you a link here to that Department of Health guidance to help local departments of health as they work with school districts. One piece of that document is a regional risk matrix. The state of New Jersey was organized for this purpose into 6 different regions, and there was a risk assessment system that was put into place to classify each region as either a low, moderate, or high risk. Different protocols that would be in place depending on your risk level. Half of our state is now considered moderate risk as opposed to low risk. So we do have a number of regions of the state who do currently fall into that category. And Dr. Yankus, it's important to stress that these categories are fluid. As we enter the flu season, we're likely to see upticks in numbers, and we may have more categories moving into that moderate area.
What's important about the regional risk matrix is that we need to be nimble. As we've said, our state coming from the south going north has gone from the low to the moderate risk. It may flip again. We have to be aware that as times change and we close ourselves in the winter, as flu season comes, we are going to be more aggressive in the moderate range than we might have been in the low risk range about sending children home for medical clearance or sending children back home for time out of school to recover. We have not stopped sound medical judgment, which you all have practiced for many years. And I rely as a school physician on nurses' judgment to do what they've always done well. However, we do know in the middle of a pandemic, these matrices do give us some chance to compare the confirmed versus the unconfirmed COVID cases and the ability to make judgments. But we will be more aggressive this year as we go from low to moderate.
Absolutely. So one piece of this guidance does deal with symptom-based exclusion of students and staff members. So we have to recognize that we have to have plans in place to isolate students with symptoms of COVID that could develop during the school day or appear when you are doing the initial screening for students entering the building. For school settings, the Department of Health recommends that we isolate students if they have at least 2 symptoms from this first list, and that list includes fever, chills, shivers, muscle aches, headaches, sore throat, nausea or vomiting, diarrhea, fatigue, congestion, or runny nose, or if they have one of the symptoms from the second list: cough, shortness of breath, difficulty breathing, new olfactory disorder, new taste disorder. Now, there is built into the guidance the ability for there to be an explanation of a specific symptom. So if you have somebody who is experiencing allergies, has a doctor's note, Dr. Yankus, I would imagine that person could be showing some of the symptoms that we see here.
Right. Many schools are using this information as a screen to come into the building. So faculty and students have already taken this before they walk in.
That's right.
It is still the criteria for isolation. But again, what's important is to understand that there are conditions that are chronic that have nothing to do with SARS-CoV-2, that such as runny nose. We know that as the heat goes on in buildings, those children with dust allergies will start to have runny nose. That does not exclude them from school, which is why there are 2 of the symptoms together: fever and runny nose, myalgia and sore throat. Again, you have the opportunity, and particularly because most of you know the students in your building well, to be able to make intelligent decisions on who goes and who stays.
Absolutely. So we do know that, of course, that there are certain individuals and groups of individuals that are at greater risk if they do contract coronavirus. So the CDC guidance has identified those who are at greater risk. We know individuals 65 and older are at greater risk. We know that individuals with underlying medical conditions, particularly if they're not well controlled, are at greater risk, and we see a list of those conditions here. I meant to, but did not update one of those conditions. The CDC did change the body mass index standard to 30 or higher instead of 40 or higher. And Dr. Yankus, that does include a significant portion of our population, doesn't it?
It includes a significant part of the population as well as a significant part of the faculty. What's not listed is pregnancy.
That's right.
Where normally we would have teachers in the first trimester of their pregnancy continue to teach, some even into the second. Many of those teachers now, from the start of their understanding that they are pregnant, have decided not to teach other than virtual.
And the CDC has recognized that as well. We should have added that to the list too. So that was a recent addition to this list of underlying conditions. As we're thinking through these issues, we have to be careful about accidental disclosures of private information. Right? Everyone is going to be pressing folks to know who is the student, who is the staff member who either is or is suspected to have COVID. So it is permissible in very limited circumstances under FERPA to release personally identifiable information. But I do want to stress that FERPA is only one tier of what you have to consider. We have that federal law. In some cases, we have HIPAA. Generally, you're governed by FERPA, not HIPAA. But we occasionally have to think through HIPAA issues as well. And you have state and local requirements that kick in. But just under FERPA, if you had what was considered an emergency that required a disclosure of personally identifiable information, you're able to do that. And we look at the totality of the circumstances. Is there some articulable and significant threat to the health or safety of that student or other individuals? So you have, EMS personnel responding to a specific emergency. You have somebody exhibiting multiple signs of coronavirus. You've just gathered information that the person was in close contact with someone with coronavirus. That's a time where you would be allowed to divulge some specific personally identifiable information to those responders. You are given the benefit of the doubt if you have a rational basis for disclosing some personally identifiable information. So, the U.S. Department of Education does not want to second guess districts if you can document why you're doing it. But as I'm sharing this information, and we need to because it's federal law, I do want to stress that it is the exception and not the rule. Very much the exception that we're going to ever share the name of an individual. So the assumption is that we don't need to do that. And in the vast majority of cases, you would not need to. If we ever have to, if we have to share the name, we actually do need to document that. So we do have to document who the information was shared with, why the information was shared. Parents have a right to know that the information was shared if we're sharing personally identifiable information to make sure that we're thinking this through and the parents' rights and students' rights are protected in this process. As far as the role of the school nurse, for the vast majority of you listening, I'm guessing you're in that role. We have to be aware of our responsibilities. So, Dr. Yankus, it's important to, I think, stress that we have a whole range of responsibilities for school nurses that haven't changed.
Right. It is still not your responsibility to identify the COVID positive kid to the English teacher who wants to know who in my class is positive. All they need to know is there's a positive case. It is, been very difficult for some nurses to withstand the pressure of administrators, in other words, to reveal information. It is no different than if you had a youngster in school with HIV, which is also a confidential diagnosis. We recognize that for a lot of school nurses, the issue of boundaries were very clouded during the pandemic when it started, because information changed daily, our regulations changed daily, and what was expected of us changed frequently. And administrators don't often follow it as carefully as you all do, and we needed to educate them a great deal as time went on. So the role of the school nurse as the medical person with 2 feet on the ground changed considerably. But again, you know what your responsibilities are, and one is certainly not, is to protect your own boundaries for your own safety.
So certainly one of those boundaries that everyone likes to tempt is having the school nurse start in some way providing treatment for their colleagues and, providing medication, doing some sort of medical assessments for colleagues. It's one thing if there's an emergency issue and your training kicks in and you're helping deal with an emergency situation involving a colleague, but you should not be expected, and it's really inappropriate to ask the school nurse to provide regular ongoing treatment of any kind for staff members. And I know, Dr. Yankus, that is one of the areas where there is some pressure sometimes on the school nurse.
The pressure for the school nurse to give me an Advil, please, or some Tylenol, or would you check my blood pressure? The doctor said it was X. He said, get it checked again. Unfortunately, every time you do that, you're not documenting it, and you're also handing out medication to somebody whose medical record you don't have, and you are essentially treating them. And I would recommend, again, if somebody wants an Advil, that you say, oh, I'm sure somebody else in your department has it, or to recommend that they go back to the doctor or go somewhere else to get it tested. It isn't up to you to be treating staff. Your job is to treat school students.
I apologize for the sound issue. I just was moving to a more quiet place. As we work from home, that will happen from time to time. So sorry about that. Uh, as we think about these issues, we also have to be aware if we do have a staff member or student who has tested positive. Again, the assumption is that we're not going to share personally identifiable information. You do have in the guidance from the New Jersey Department of Health sample letters that would go out when there has been a confirmed positive result for someone who has been in the school or someone has been in close contact with that particular individual. So you have sample letters that allow you to get the information out you need to without sharing personal information in almost all cases. As far as your role in contact tracing, generally speaking, it's your job to share the information you have as school nurse regarding any potential close contacts that an individual might have had with others. And that close contact is being within 6 feet of somebody else for 10 minutes or more. So sharing the information you have. But it is possible, given the limited capacity in some local departments of health, that in some cases, you're going to be more actively assisting with contact tracing. So Dr. Yankus, again, that will vary from community to community.
It'll vary on the number of workers in the local health department. But again, I think nurses are trained in this to some degree. Contact tracing is not new. We've had contact tracing for years for other diseases, whether it be whooping cough, syphilis, or outbreaks of tuberculosis. Contact tracing has been one of the public health cornerstones in eliminating outbreaks being defined as more cases than you would expect to find in the course of a normal period of time. So the school nurse is generally, again, enforcing the health and safety protocols and a contact tracer for the community she's in, which is in fact your school.
And if you do see health and safety protocols that are not being followed, your enforcement authority is not always as strong as you would like it to be. You do want to make sure that you are documenting your concerns and notifying school administration if you see students, staff members, parents, visitors who are not following health and safety protocols, and doing that as quickly as possible because the amount of exposure does increase the risk exponentially. Sorry about that. As far as other implementation challenges, creating sufficient space for isolation and supervising that space, we need to anticipate that we will have a large number of students who are exhibiting some of the symptoms that we talked about before. As we enter flu season, I would expect that those numbers will go up pretty significantly, don't we think, Dr. Yankus?
As we get into the winter and as flu season comes along, yes, there will be more use of isolation areas. Remembering that the way the isolation area was defined was that the child is wearing a mask, is 6 feet apart from any other child in that room, that the room has ventilation, that it's supervised, and that the parent who is picking up the child is not coming into the isolation area. But the child is being escorted out of the building to the door to identify the person who is taking the child home. But we are discouraging parents from coming into the building, particularly into the nurse's office or isolation area, to pick up their child.
One of the other challenges I wanted to highlight on this particular slide is those parents, families, sometimes staff members who choose to travel to states that are on New Jersey's travel advisory list, where we're advised to isolate and quarantine if we've been to any of those states. It is very difficult sometimes to get honest information on this issue. You'll have a family that decides to go away on vacation. Right now, New Jersey has 38 states on its advisory list. So if somebody has gone away to another state, there's an excellent chance it's one of the states on this list. And that person should not be in school for the next 14 days after they return from that state on the list or from another country. So getting accurate, honest information on this is incredibly important. And I know that some districts have thought about perhaps, extending the amount of time of remote instruction so that we have 2 weeks of remote instruction after any extended holiday break. But I think Dr. Yankus and I both agree that's probably not a great strategy, since you're likely to then have families just extend their vacations.
Not only extended vacations, but the other thing that we find is that hold your horses. Kids are coming back from college in states that are in those quarantine advisory states. So the questions are going to be, if my older brother comes home from UT in Texas, does that mean everybody at home has to quarantine for 14 days? Or my parents went to pick up somebody in Delaware who's now on the list. Does that mean my parents have to quarantine, but can I go to school? I mean, we're getting these questions on an everyday basis that sometimes require the Department of Health to answer. I just got one at lunchtime from one of my schools where people came to visit. Relatives came to visit from one of those states. Now they're quarantined at that home for 2 weeks in New Jersey. But does everybody else have to quarantine? My local health department said no. But another health department could say yes.
Yes. Yeah, and I do worry about that, getting inconsistent answers at times from our local departments of health as well.
Right.
Another one of our implementation challenges deals with the fact that we have so many staff members who are at risk. One study showed 42% of adults are potentially vulnerable to COVID-19 and significant risk of severe reaction to it. When we look at that long list of conditions, I think that probably is a reasonable estimate. We also have to be aware that COVID-19 has had other impacts. For example, the number of overdose deaths in New Jersey this year is on pace for a record high. And COVID has been seen as a major contributing factor to those overdose deaths. We also see other challenges. Here's an example of a Georgia school district where on the very first day of school, a student took a video that showed that basically nobody was wearing a mask, very few students were social distancing, and the district's initial response was to punish the student who exposed that the public health protocols were not being followed. That cannot be our response if this sort of issue comes to light. The response needs to be, thank you for sharing this information. We need to address the underlying public health issue, not punishing the person for reporting that information. But be prepared. We're asking people to completely change their behaviors. We also could see cases where staff members just refuse to wear a mask. Here was an example where a bus driver said, I don't believe in the science, I'm not going to wear a mask. That driver was terminated. And certainly there is no ability for a staff member to refuse to wear a face covering. So I know you've heard some of these cases too, Dr. Yankus.
Yeah, and I want to comment on the 42% of adults that are vulnerable in schools as faculty. The school medical office rarely, if ever, knows the medical history of the faculty members. But this year, we have become very well aware through notes from their own doctors as to why they could or couldn't teach in person. And so we have become very aware of, again, more confidential information or information that could theoretically be actionable by the medical office and the school nurse during the course of the year for some faculty members. But I think we are finding that in some schools, whole departments were unable to be present to teach because of age, conditions, previous medical conditions, or what is never seemingly mentioned is people who live with people who have medical conditions that would suffer if somebody came down with SARS-CoV-2.
Absolutely. We mentioned that existing requirements are still in effect, including existing immunization requirements. There is some research that suggests that upwards of 40% of students may not have received required immunizations during the COVID-19 closure. But Dr. Yankus, we have to hold strong on those immunization requirements, don't we?
We do. There is no grace period. The statutes and the administrative code in the Department of Health for immunizing has not changed. We recognize that most pediatricians' offices were not able to handle this in the spring, that many were virtual, and many students did not get immunized. And now, but on the other hand, over the summer, there was plenty of capacity to immunize students. And we recognize also that as the flu vaccine has become available and should be given by the end of October to most people, the opportunity is there to catch up on those immunizations. Let's not forget, we had a measles outbreak in New Jersey and New York and in the United States prior to COVID-19. And it will come back again if we don't keep up our immunizations. So I don't think any school system is looking for flu, COVID, and a measles outbreak at the same time. That for sure would close the system down.
Yes, yes. So there have been some recent legislative developments that we want to make sure that you're all aware of as well. Not all directly related to COVID, but they're impacting how we operate now. So this particular legislation, Paul's Law, it's called, was signed in January of this year. It did go into effect immediately, and it authorizes parents or guardians to request an individualized healthcare plan for students with epilepsy or seizure disorder, which includes specific actions at times for non-medical school staff. And it did take effect immediately back in January of this year. So the school nurse is charged with developing a plan based on the parent's submitted seizure action plan. And that seizure action plan is a comprehensive document provided by the student's physician, advanced practice nurse, or physician's assistant. And that includes, but it's not limited to, information regarding how does a student present when there's an onset of a seizure, what are some of the triggers that we want to be aware of, what are daily seizure medications for that student, what sorts of seizure first aid should be provided, what additional treatments we should be aware of. So Dr. Yankus, I imagine it's critical that we make sure that plan is in place and that we've thought through who among the staff need to be provided some training to deal with a particular student.
Right. I think this formalizes something that we've all done informally before, but what it really reaches out to is not only just the teacher of the classroom, but the gym teacher, the lunchroom aide, other people who will have contact with the student who has a known seizure disorder. There are many that are not in good control. There are many who will be new and have their first seizure at school. But this really, Paul's Law applies to formalizing the instruction for other school staff related to individuals having seizures.
And for our folks, of course, as in many areas, the nurse is taking a leadership role here. So you do have a major responsibility to develop that plan based on.
And a comment on that, as you point out, David, in your slide, it can be written by the student's physician, advanced practice nurse, or the physician's assistant. That is true for most things that go on in schools right now, with the exception of the sports form for participation, meaning that for the daily COVID year for participating for sports, the NJISSA has been very clear that only an MD or DO can sign those forms.
That's right. A couple other pieces I want you to be aware of. This was also signed January 9th, requires school districts to emergency action plans for responding to serious or potentially life-threatening sports-related injuries. And that has to be in effect for the 2020-21 school year. It was actually amended recently to say that those plans also need to address any sort of emergency actions related to coronavirus for somebody who has a sports-related injury. So I'm not sure exactly how that would play out, but it is now included as part of what we have to consider in developing those emergency action plans. We also have to follow the NJSIAA rules on heat participation policy. So when we have individuals who are in direct sunlight at practice, we have to pay attention to the wet bulb globe temperature tool that was developed and make sure that we're limiting any potential exposure or risk for those student athletes.
These two public laws carry an unusual, do not carry a burden on the school nurse because generally you're not there. You're not there during the practice and you're generally not there during the sporting events. This really does relate to the fact that the administration has to bring coaches, athletic directors, many of whom who are employed only to teach in that system one particular sport, but are not on the faculty. So these two laws really relate to the fact that people in charge of the sports program are up to snuff on these two laws.
Absolutely. This is a good statute that was put into place, Chapter 85. It establishes the position of state school nurse consultant in the New Jersey Department of Education. You know, as the department is developing and rolling out policies that impact on public health, it's critical to have a knowledgeable person at the department with that experience in a high-level leadership position. So I'm sure you're happy to see this as well, Dr. Yankus.
Hallelujah.
Yes.
In the name of Marilyn Kent and Christine DeWitt Parker and all those people who put up with the Department of Health and all the Department of Education, but they were available and they certainly were available to us. And I'm so grateful that the New Jersey State School Nurses Association successfully lobbied to get one of their own back into the Department of Education.
Absolutely. The next statute we're not so thrilled with. It delays the physical education requirement for students participating in athletics in the fall. And I know this is something you've been very concerned about, Dr. Yankus.
Right. We since the early 2000s counted on the fact that every athlete would have an exam within 365 days of participation in the sport. The reason for that came out of the fact that we were trying to eliminate sudden death on the field, which happens to a number of kids every year throughout the country. What we have found was there was tremendous pressure on the legislature by several legislators this year to say that 365 days is okay, but you don't have to. Theoretically, it allowed people to play fall sports, keeping in mind that New York, Connecticut, and Pennsylvania didn't have fall sports, but New Jersey did, that essentially you could play without an actual physical that was up to date through the fall sports season as long as you had one by the end of the season.
Right. So that will require follow-up.
Yes, and it falls on the school nurse again to follow up.
Absolutely. Another new piece, there was a concern among legislators, understandable concern, that some students this past spring were denied the opportunity to participate in athletics, and that can cost real opportunities for students. And there was some loss of educational benefits as well, as we were in this period of remote instruction. So we do have legislation, Chapter 41, that allows those students who would be graduating in 2021 or 22 to be eligible to continue taking courses in the school district or perhaps through a community college, and in either event to continue to participate in athletics in that school district. So you could have somebody who, for all intents and purposes, really is no longer your student, continuing to participate in athletics, continuing to have to follow your requirements as far as your code of student conduct, and certainly having to follow the requirements for physical examination as well. Comments on that one at all, Wayne? We also wanted you to be aware of other resource documents that are out there to address some of the latest developments. So on our website, we give you a link on the New Jersey Department of Ed website, U.S. Department of Ed, CDC, and the New Jersey Department of Health. We've also done a tremendous amount of free training over these last 6 or 7 months. So we give you links in our PowerPoint to a number of free webinars from March all the way through the end of the summer. And with that, I do want to open this up. And here's another training that we want you to be aware of. Last thing I'll mention before we open it up to questions. Dr. Yankus and I were proud to contribute to what we think is a wonderful textbook for school nurses, School Nursing, the Essential Reference. We did work together to contribute a chapter to this comprehensive textbook that walked through a number of difficult ethical issues with obvious legal components that school nurses have to deal with, unfortunately, sometimes on a regular basis. So Dr. Yankus, I know we appreciated working together on that textbook.
Well, I appreciate it, but I want to say how much I appreciate, as I do every year for 29 years, to the school nurses that work so hard to do a good job, keep their schools safe and healthy. And I know that this year there have been undue and unusual burdens placed on you, and it is going to be so important that we continue to work together as school physicians and school nurses to continue to have good outcomes. But congratulations on all you do, and thank you so much. Questions?
We wanted to leave a good amount of time for questions, so let's open that up.
Great. Thank you, Dr. Yankus and Mr. Nash, for your presentation today. Just a reminder, if you have any questions, please submit them in the chat box. At this time, we have a few questions, well, quite a few questions. First question is, please clarify if, as school doctor, I can only approve school pre-participation done by an MD or DO. I have plenty filled out by PAs or ANPSs.
Yes, I'm sorry if that was confusing. The actual 6-page pre-participation form can be filled out by a physician's assistant or an advanced practice nurse. This summer, when the NJISSA came out with their pre-practice forms that students had to have a clearance for practice, that had to be an MD or DO. But the New Jersey State PPE form that we have used since 2004 and modified again in 2006 and 2013 can be signed by physician's assistants and advanced practice nurses.
Perfect, thank you. Does the healthcare plan only get written at the request of the parent or guardian, or is this something that the nurse should create upon receipt of a seizure action plan?
Well, you're receiving the seizure action plan most likely from the parent. That's what the statute talks about as far as the process. That information is coming from the parent or directly from their parent's physician. So at the request of the parent, the information has been provided to the school district that prompts the development of that plan.
Perfect, thank you. Will the parents be held liable if they knowingly send their sick child to school and are unable to pick up the child in a quick enough time frame?
Liability that's a great question. Unfortunately, there's plenty of liability to go around. So sure, a parent can have some degree of liability for potentially putting others at risk. That does not excuse the school district from their duty of supervision. So even if the parent made that bad choice, allowed the student to come to school, if there's any reason that the school district should have picked up on the symptoms, there could be liability on that side as well, not just with the parent.
In this pandemic year, many superintendents have sent out letters home to parents to say, it is our expectation that you will have someone available to pick up your sick child within a certain time frame. If you work distantly and not at home, that it is your responsibility to find another adult whom you trust to pick up your child. I think, again, this is the teamwork with your administration, because we recognize that some parents who are in a position that they can't leave work to go pick up their child, but it is their responsibility, not the school's, to find someone who can pick up the child.
Which masks should be used to conduct screenings for students, especially preschool students? Should an N95 be used, or is a cloth mask, surgical mask sufficient?
Generally, for a non-sick student, a regular surgical mask that's changed frequently should be sufficient. If you have any concerns, have a face mask put over the mask. Not everybody necessarily needs an N95.
And I have seen that in a number of districts where they are providing a face shield as well for those
Correct.
staff members who are involved in doing the screening process.
Do you know if there's any plan in place for screenings to take place in the schools this year?
Screening wasn't undone. That is to say, the statute or the administrative code for screening has not changed as much as we all petitioned for it to change. It didn't. So yes, screenings will still take place.
Would you recommend schools be remote 14 days post-holiday to prevent COVID-19 outbreaks in schools? I noticed that throughout years, families travel during the holiday and gather together. As a result, many children coming in with colds or flus after winter or spring breaks.
Yeah, we mentioned this briefly in the formal presentation. If you do that, I understand the outcome you're trying to reach, but there is a real potential that people will extend their vacations and you still won't get the benefit of the person actually staying home for 14 days after returning from another state or country.
Yeah, remembering that isolation is different from quarantine. Isolation is the sick person is being removed. Quarantine is we're removing the well people from the sick person so they don't get sick, or we're waiting to see if they do become ill. In a perfect world, yes. After a holiday, it would be wonderful to have no school for 2 weeks and make sure that everybody's well. But as David said, life doesn't work like that. And so it would be a lot of time where kids are not in school who otherwise could be.
Would it be possible to re-explain sports physicals and COVID? Is there another release form that will be added?
There are two forms for sports. There is the pre-participation form, which is given once, and that is the 6-page form. We've had that a long time, and anyone other than a chiropractor can sign that. When you get to a physician's assistant nurse practitioner or an MDDO, there was a rule starting this summer before official practice started in the fall that if you were going to play a fall sport, the NJISSA required that you do a similar verbal screen, like, do you have loss of taste or smell, whatever? Have you been to a COVID state? Do you live with anybody with COVID? And then that you were cleared to play, that had to be signed by an MD or DO. Honestly, at this point, because fall sports are well in play, that's probably not an issue anymore. But yes, that was an MD, totally unrelated to your ability to practice that the school nurse get.
Now, I have not reviewed yet. I know it's just out, the winter guidelines from NJSIAA.
Right. Just came out 48 hours ago, yeah.
Yeah. If you had a student who didn't participate in fall sports and the winter sports were their first sport, you may still have that requirement for the sign off by the MD.
It was simply a screening mechanism that they used to be handed to the coaches, not to the nurse. The nurse still gets the official PPE, pre-participation form, and that is our gold standard.
Thank you. What about someone being HIV positive? How do you address this medical concern?
Well, it really depends on what the medical home wants for the child. We certainly have children who are HIV positive in school doing very well. We don't particularly have any indication that they are more susceptible to COVID than anyone else. A lot, of course, because these children are followed so carefully by their infectious disease doctors. If the viral load changes, if their white count drops, if they are edging into AIDS or things like it, then they probably would be virtual as opposed to hybrid or in person.
But could be true for a staff member as well, right?
Correct. There's no prohibition. And it is still a confidential diagnosis. So most of us in school will not know who these people are.
Okay. If we have a staff member who does not feel well, should the school nurse assess them, or should they just go home and see their own healthcare practitioner?
The school nurse should at least hear what is wrong and what their concerns are, and make the recommendation to them and the principal that they be removed from the school and go see their medical home. The nurse shouldn't be diagnosing. She should be recommending that the individual faculty member seek medical care. But
Again,
they
if there's
should be
some,
removed from school.
if there was some emergent issue, the school nurse would have some level of training to deal with some emergency situation that could come up with a staff member.
Right.
I have a family that recently traveled to Florida. They are stating voluntary quarantine according to the nj.gov and feel that they have the right to return before the 14 days.
They do not. So if you're aware that a family has traveled to one of those states, you absolutely have a right to hold them to the 14-day quarantine period. That's been made very clear in the guidance that's come out from the governor's office and the Department of Health.
Okay, perfect. So we were told by our health department that alternative diagnosis written by a doctor needs to be something other than a URI, viral infection, symptoms other than COVID. In our county, many doctors are writing notes with these diagnoses. Are doctors aware of the need for clarity for a student to come back to school without a COVID test before 10 days when they are having symptoms?
Most doctors are not aware of what schools need and what the requirements are. Most doctors are not necessarily doing testing. Testing costs money and it's a medical decision to do it. And we are not requiring it necessarily for students to come back to school. So if I understand the question, a doctor can write a note and say this child has an URI, and we are essentially bound to accept that note that that's what the diagnosis was. We have to leave it up to the medical home to make that decision.
And the protocols do change somewhat when you move into the moderate or high risk categories.
Correct.
So you do want to be aware of that, and you do have some more stringent conditions for returning to school.
Workers' comp considerations with COVID-19 claims, how would you handle?
Workers' comp cases are incredibly complicated. As a theoretical matter, absolutely, you can have a workers' comp claim that would arise from contracting COVID in the school setting. As a matter of proof, it is exceedingly difficult to prove that that's where you contracted COVID-19 in the workplace. So that's where I think there will be major legal disputes actually proving that's where the individual contracted the disease. Now, if a district's protocols are not effectively enforced and there is compelling evidence of a widespread non-enforcement, the ability to convince a judge that you probably contracted it in school certainly shoots up.
Thank you. How should the school nurse address staff with chronic allergies, sinus headaches, etc.? On screening enter the building, the staff will mark yes on the screening. Can those staff members still enter the building?
You can, if you have gathered that information and understand why you're seeing those particular signs from that individual. And that's a matter of coordinating in communication. So Dr. Yankus, I'm sure this is coming up.
Right. Two of my systems use a screening questionnaire that's put out at 3 a.m. every day, and you answer it on your cell phone, and it has those questions, but it also has parentheses that say, for some other reason. In other words, runny nose for known reason, chronic whatever for known reason. Right. Then you can click none of the above.
Yeah, so the Department of Education guidance did say if you're exhibiting these signs, unless they are otherwise explained. So when you have sort of a medical documentation that says why you have the runny nose, that is otherwise explained.
Okay. Another one just came in. What kind of advanced PPE do you recommend for students that have autism or behavioral problems?
This has been a big issue. Again, we try to start with the caseworker and the individual teacher to try to get mask wearing if that's possible. And it has been in some cases that out of a 3-hour class, maybe for 20 minutes, there'll be a mask on, or 30 or whatever. The second step, obviously, is if a mask isn't possible, some children will wear a face shield. and it is less threatening because it's not right up against them. It does have a little bit of space. You can move it forward. And so the mask is less of an issue. It's not perfect, but it's one step better than nothing. And then the third thing is you really have to work with the director of special needs and the caseworker and the family as to how that person continues to fit in that class in light of our pandemic. It is a different year. And so rules are a little bit different in terms of what your federal entitlement might have been. But what we found is that face shields work well for a lot of kids. You can decorate them, put butterflies on them, paint them. And if that's a distraction, then there are other things you can do. If there's absolute inability to wear any protective device, then it really is a discussion between the school doctor, the director of special needs, the principal, and the person's doctor as to whether they should be virtual or be taught separately.
Right.
So as we're endanger the class.
As we consider what is the appropriate school setting or educational setting for a student, you are allowed to consider the health and safety of other students as well. And that entire analysis is very different, as Dr. Yankus said, during a pandemic.
Health screenings are often forgotten in the morning and children are already in their classrooms. Shouldn't they be kept out of the building until screening by mom is done?
Yes.
Yes. You
That's the whole point of screening.
Yeah. You have to have an airtight system so that you realize which parents did not fill out the form that particular day. The whole point is gone when you're 3/4 of the way through the day before you realize that the form wasn't completed.
Right. And the form we found very creatively done. I mean, if it's on the computer and the kids don't have phones, that's one thing. You can print it out and slap it on the back of the backpack. I mean, there are any number of places you can put the form so as not to miss it. And if it's not there, they don't come in.
If a parent was out of the country, does the child need to quarantine?
That's a great question. And again, the parent who is out of the country will now quarantine to see if they become ill. The child does not have to quarantine while waiting for the parent. But if the parent comes back COVID positive, then the child is in fact quarantining as well.
Yeah, and potentially I would think you'd have a real conversation with your Department of Health if the parent is exhibiting symptoms of COVID-19 and has traveled to one of those areas, depending on your risk level.
Right, and also the country. You know, did they come back from Korea or Canada versus from Yemen or something?
Yes.
Is there any way that we can enforce a 14-day self-quarantine after travel?
You can certainly say that you have to wait 14 more days before you're coming back into the school setting in person. You can enforce that. That's a reasonable requirement that is in line with public health standards. So that's something the school district should be looking to do in consultation with their Department of Health.
Yeah, but quarantine is voluntary, but as David said, within the school system, because it is a unique community, to avoid it becoming a super spreader convention, we can weigh heavily on the Department of Health to encourage people to do it. And remember that the Department of Health ultimately and historically does have a lot of oomph when it comes to making people stay put.
And really keep in mind what you're doing here is just altering the way that child receives their education. You're not denying services during that period of time.
Looks like we have, oh, here comes another question. Here we go. Good, because we have about 10 more minutes. We're extending the session a little bit because of our later start. Do you have any recommendations for how to handle specific staff and students who fit in the high-risk categories for severe illnesses due to COVID-19 when our area is on yellow? The recommendation says something about offering alternative learning or work opportunities. Could this be seen as discriminatory?
It would not be seen as discriminatory to work with those who are at greater risk. That's sort of an objective, defensible reason to be working with students or staff members. I think it is important as a matter of trust to share information with staff members about underlying medical conditions that could put them at greater risk, to explain the process for a staff member to make a request for a reasonable accommodation, and to, in good faith, engage in what's called an interactive process with that staff member and see if you can either provide the accommodation they're asking for or some other accommodation to reduce the risk for that individual.
How would you approach a note from another doctor that gives permission for an autistic student not to wear a mask? Parents insist on in-person learning, even though I recommended virtual learning to protect others in the classroom.
I've had to deal with this a lot. Again, you have a couple of options. One is to certainly have the school physician talk to the physician of that child and ask for an explanation, because many of the physicians treating the individual child are unaware what the classroom atmosphere is like, big class, small class, individual attention, and that helps. The other is, again, to establish a protocol in your school. Who gets the note first? The nurse gets the note goes to the caseworker gives it to the special needs chair of the school system, or the assistant superintendent for special education, and then ultimately with the school doctor's consultation. Meeting with parents generally doesn't work with the nurses and doctor because it often becomes adversarial, but meeting with the caseworker and the division of special needs, those are people they've worked with for many years and are usually able to make those adjustments. I would not on face value accept any note from a doctor that says they can't wear a mask. You have to explore it, and you have to have good reason, and you have to be able to turn to some parents and say, we're unable to keep your child in that class, but we will continue providing services in another way.
And many children with autism are perfectly capable of wearing a mask. So you don't want to have some blanket assumption that a student can't because of that particular condition.
Right, but the nurse should not have to bear the burden of that entirely. That should go up the chain.
I have a non-COVID question. Does the state of New Jersey require 2 MMR vaccines or 2 measles? Specifically, does Haley's Law cover mumps and rubella?
Haley's Law, well, the answer is yes, the state requires 2 of the vaccines. Haley's Law, which involves drawing blood titers, means you've had the first MMR. It is not meant to protect you from having none. You've had the first MMR, now you're going to kindergarten, and a parent is invoking Haley's Law to say that I'm not getting the second MMR. As we know, titers vanish quickly over time, particularly if you've only had one of the vaccines. But the state many years ago was forced to, did pass this, and there are parents that will invoke it. Frankly, not many, but it does exempt you from the kindergarten requirement for the second MMR. Does it exempt you from mumps and the rubella part of it? It was meant for measles, but it has been interpreted as all 3. But we advise as pediatricians to the parents that, if you have a couple of options, but just please know that your child is not protected. And again, they fall into the category of people with medical and religious exemptions from immunizations, that if there is an outbreak, meaning more than the expected number of cases, those children are sent home. They are not allowed to stay in school. Now, this year they would be educated virtually. Otherwise, they would not, because they can return to school as soon as they are immunized, which could be that afternoon.
I am the school nurse, and I am at high risk due to my personal medical issues. I've been told that I must return to work in person as my job is essential. Any advice?
So a couple of things here. A school district is permitted to go through an analysis and say that it would cause an undue hardship to allow certain staff members to work remotely. given the nature of the job that they're performing. So probably a school district could say that we're unable to give you an accommodation of working from home as a school nurse. But you are entitled to some accommodation. So the sorts of things we talked about earlier, enhanced PPE, putting in place strong protocols to make sure that the person isn't at greater risk, are very important. So you want to try to document all the other ways that we can help keep that person as safe as possible. And certainly enhanced PPE would be a huge part of that.
Great. You mentioned earlier working with principals. How do we address issues where the district states isolation rooms should be separate from nurses' rooms and have ventilation, and your principal is trying to put it in your office or waiting room with no ventilation without overstepping your role?
Sure. So whenever you're dealing with these sorts of issues, a big part of it is education. You know, school principals have so many things on their plate, they're dealing with so many issues. You want to be able to move on to the next issue. So trying to perhaps slow things down a little bit, point specifically to the provisions in the Department of Ed guidance, point specifically to this provisions dealing with ventilation systems and isolation rooms. We always encourage any school principal who wants more information to reach out to us. You know, I work under the umbrella of the New Jersey Principals and Supervisors Association, and we are happy to walk through all of these public health and safety protocols with any school principal in the state.
So we have about 5 more minutes, so I might be able to get through a couple more questions. Just to hear it from a legal standpoint, we should never complete BP screening on staff. This has been done before and we document it, but want to be covered.
Blood pressure screening you're talking about. It's not for the school nurse to be taking the blood pressure of the staff members. Now, again, if there is some emergent issue going on and it's part of the nurse trying to assess an imminent emergency, that might be part of what you do. But it is absolutely inappropriate to make that part of a nurse's regular practice and protocol.
Can a parent or a doctor write a clearance note for their own student for PE?
I'm sorry, what was the question?
Can a parent who is a doctor write a clearance note for their own student for PE?
It's unethical, but if they're a licensed New Jersey physician with an office, as opposed to a retired grandfather, yes, they actually can. Yeah. But again, it's been one of my mentors in school health who was the school physician at Lawrenceville many years ago would call them up and say, now, John, did you really do this physical? Did you really actually attend this? And so you can challenge it, but yes, we do have to accept it.
How long do you need to hold on to the student daily screening sheets?
Oh, interesting question. Potential litigation, you want to keep in mind, you know, one reason you hold on to things is because of potential litigation. If there was a claim under state or federal law, typically you're talking about a 2-year statute of limitations. So I would be holding on to an electronic version of these records for that period of time to make sure that you can establish that you followed appropriate protocols.
Okay. Yeah, and that looks like that is the last question that we have for you both. So on behalf of the New Jersey chapter of the American Academy of Pediatrics, I would like to thank you for joining us today for this informative workshop. Thank you, Mr. Nash and Dr. Yankus. So if you guys want to just sit tight, we're going to be going back to the main session room just for a few closing words, and thank you.
Thank you, everybody. Everyone, please be safe.